Welcome to the deep dive. Today we're tackling a really common digestive issue, diverticulitis. And, well, the guidelines have shifted pretty dramatically.
They really have. For years, the approach was quite fixed, almost reflexive. Pain, rest, maybe a liquid diet, definitely antibiotics.
Right. But the standard we're looking at today, based on solid evidence, kind of flips that script, doesn't it?
It absolutely does. This standard aimed to clear up a lot of confusion. Practice varied, so much different advice on rest, diet, and especially antibiotics. It needed unifying.
So what's the headline? The big takeaway right up front.
For most cases, the uncomplicated ones, the policy is surprisingly less is more. No mandatory bed rest, no special diet needed, and crucially, generally no antibiotics.
Wow. Okay, that's definitely not what most people probably think. So let's break this down.
Yeah, we should probably start with the basics. What are we actually talking about?
Good idea. Let's define the terms, then figure out how it's diagnosed, and then get into that newer treatment approach.
Sounds good. So first, a diverticle. Think of it as a small pouch, like a little bulge, that pokes out from the wall of your intestine, usually the colon.
Just a little weak spot in the muscle layer.
Exactly. And when you just have these pouches without any inflammation or symptoms, that's called diverticulosis.
And that's common, right? Like really common.
Incredibly common. Probably the most frequent abnormality found in the colon in the West. Something like half the population over 80 has diverticulosis.
Okay, so having the pouches is one thing, but diverticulitis, the itis is part, that means inflammation.
Precisely. Diverticulitis is when one or more of those pouches gets inflamed or infected.
And how many people with the pouches actually get the inflammation?
Estimates vary, but maybe around 15 to 25% of people with diverticulosis will develop diverticulitis at some point.
That's still a lot of people. And you mentioned the West. Is there a geographical pattern here?
Oh, absolutely. It's strongly linked to the quote-unquote Western lifestyle. The incidence is way higher here than in, say, Africa or Asia.
So diet and lifestyle play a big role.
It really seems so. Studies looking at immigrants, for instance, show their risk is low initially, but it climbs the longer they live in a Western country. Suggests our diet, maybe low fiber, high processed foods, contributes.
Interesting. And even where it happens in the colon differs.
Yeah, in the West, it's overwhelmingly left-sided, like 90% of the sigmoid colon. But in Africa and Asia, it's more often right-sided. Fascinating difference.
Okay, so someone comes in feeling unwell. How do you suspect diverticulitis specifically? What's the key symptom?
The absolute classic sign is persistent, sharp, kind of stabbing pain, usually in the lower left part of the abdomen. And it typically develops over a few days. It's not usually sudden onset like some other things.
Is there fever too?
Fever is common, yeah, over 38 Celsius or under 0.4 Fahrenheit. But the pain, that localized lower left pain, is really the main complaint we listen for.
And then the crucial step is figuring out if it's simple or complicated.
Exactly. That's the branch point. Uncomplicated means you have that persistent pain. The tenderness is confined to the lower left. And this is key. There are no alarm signals.
Okay, let's talk alarm signals. These are the red flags that mean hospital, right?
Right. Immediate referral to a surgeon territory. You need just one of these. First, signs the whole abdominal lining is irritated, what we call peritoneal irritation, especially if the muscles guard or get rigid.
Like the belly becomes hard.
Yeah, involuntary tightening. Second, signs of a bowel obstruction, or ileus, like persistent vomiting, maybe specific high-pitched sounds when listening to the abdomen.
Okay. What else?
Third, any rectal bleeding. That could be diverticular bleeding. Fourth, if the doctor can actually feel a distinct mass or lump down to the other, there could be an abscess.
And the last one.
Fifth, signs of shock, like low blood pressure, hypertension, any of those five, and it's a different ballgame. Complicated diverticulitis.
You mentioned labs earlier. What about blood tests? Does something like CRP help?
Yeah, C-reactive protein, CRP, it's a good marker for inflammation, goes up quickly. In primary care, the guidelines suggest using a level over, say, 20 millimolar to support the diagnosis of inflammation in uncomplicated cases.
Just 20, that seems low.
It is relatively low compared to hospital thresholds, which might be more like 50. The 20 is a bit arbitrary, chosen because there isn't tons of research on exact cutoffs in the primary care setting itself. It just adds to the picture.
But a really high CRP, that means something more.
Definitely. If that CRP is way up, let's say over 100 millimoles again, somewhat arbitrary, but a clear signal, you have to be much more suspicious of a complication like an abscess or perforation, even without obvious alarm signs yet. That patient likely needs imaging and secondary care.
Makes sense. Now, what about pain on the other side? Lower right.
Ah, yes. That's the big diagnostic headache. Pain in the lower right can be right-sided diverticulitis, which happens, though less common in the West.
And the probably is.
The problem is it looks exactly like acute appendicitis clinically. Same location, similar symptoms. You really can't tell them apart just by examination. Both need urgent evaluation, often imaging.
Okay, huge challenge there. Let's move to treatment, specifically for the uncomplicated cases, the ones without alarm signals. This is where the guidelines got really interesting. What about rest?
Yeah, this is a big change. The old advice was often strict bed rest. The current standard says, nope, bed rest is not necessary. Patients should just adjust their activity based on how they feel. Move around if you feel up to it.
And diet, liquid diet, clear fluids.
Also, nope, no specific dietary restrictions are needed during the acute flare-up. Patients can eat and drink whatever they find they tolerate okay. There's just no good evidence that restricting the diet helps things heal faster in these cases.
Okay, that's liberating. Now, the elephant in the room. Antibiotics, standard practice for decades, right?
It certainly felt like it. But the guideline is crystal clear. For uncomplicated diverticulitis, antibiotics are not advised.
Why not? If there's inflammation, don't you need them?
The evidence just isn't there to show they provide a benefit. Randomized trials haven't shown that antibiotics speed up recovery or prevent complications in these mild, uncomplicated cases compared to just watchful waiting.
So the body usually handles it on its own.
It seems so. And giving antibiotics when they aren't needed carries risks, right?
Yeah.
Side effects, messing with your gut bacteria, promoting antibiotic resistance. So if there's no proven benefit, the balance tips towards not using them.
That requires a shift in thinking for both doctors and patients used to getting a prescription.
It really does. It means relying on close monitoring, especially that first week, making sure none of those alarm signals pop up. But for most, observation works.
What about pain relief then? If they're not getting antibiotics, but they're hurting?
Good question. Simple pain release is fine. Paracetamol acetaminophen is the recommended first choice if the patient wants something for the pain.
What about things like ibuprofen or naproxen, NSAIDs?
Those are specifically discouraged.
Why is that? They're good anti-inflammatories.
They are, but they also have known gastrointestinal side effects. And more importantly, some studies, though not randomized trials, have shown an association between NSAID use during diverticulitis and a higher risk of complications, particularly perforation, a hole forming in the colon.
Wow, okay. So definitely avoid NSAIDs. Stick to paracetamol.
That's the advice, yes.
Yeah.
The potential risk from NSAIDs just isn't worth it here.
If we're just watching and waiting, how often does this come back? Is recurrence common?
It does recur. Roughly, maybe 1 in 4 patients might have another episode down the line.
Does it get worse each time? More dangerous?
Interestingly, no. The evidence suggests that having recurrences doesn't actually increase your risk of developing complications compared to the first episode.
What about younger patients, say under 50? Is it worse for them?
They do have a higher lifetime risk of having another episode, simply because they have more years ahead of them. But it doesn't seem to be a more aggressive disease course in younger people compared to older folks. The biology of the flare-up seems similar.
Is there anyone with uncomplicated diverticulitis who shouldn't be managed conservatively at home? Anyone who needs referral sooner?
Yes, absolutely. Patients who are immunocompromised. This could be due to conditions like poorly controlled diabetes, other chronic illnesses, or medications, things like long-term steroids, prednisolone, methotrexate, or those biologic drugs called TNF-alpha blockers.
Why are they different?
Their immune system can't fight the inflammation or infection effectively. Their risk of serious complications like perforation is significantly higher. One source mentioned the risk jumping from maybe 14% to over 40%. So immunocompromised patients need a much lower threshold for referral and probably hospital admission.
Okay, critical exception there. Now let's shift to prevention. Once someone's recovered, how do you stop it from happening again or happening in the first place? What are the big risk factors?
The guidelines point to 4 key lifestyle factors strongly associated with a higher risk. First, lack of physical activity. More active people, especially men in some studies, had like a 25% lower risk.
Okay, exercise helps. What else?
Second, smoking. Third, obesity, specifically a BMI of 30 or higher. And fourth, perhaps surprisingly to some, regular NSAID use, even when not having a flare-up.
So the same NSAIDs we avoid during an attack might also increase the risk of getting an attack.
That seems to be the association found in studies, yes. Minimizing unnecessary NSAID use seems prudent for prevention, too.
And diet. We talked about the Western diet link. What's the advice for prevention?
This is where fiber comes back in. While not needed during the acute phase, A fiber-rich diet is considered possibly protective long-term.
What kind of fiber?
Research suggests diets high in vegetables and fruits are beneficial. Some studies showed pretty significant risk reductions, like almost half for high vegetable intake. On the flip side, a diet high in red meat seemed to increase risk.
So the classic healthy eating advice holds true here too. More plants, less red meat, keep active, don't smoke, watch the weight.
Pretty much sums it up, yeah. It's about overall gut health and reducing pressure inside the colon.
After someone recovers from an episode, do they need a colonoscopy to check things out?
Not routinely, just to confirm, yep, you have diverticulosis. The diagnosis of uncomplicated diverticulitis is usually clinical. A colonoscopy might be needed later if symptoms don't fully resolve, or if the doctor wants to rule out other conditions that could mimic it, like colon cancer or inflammatory bowel disease, especially after a complicated episode or if symptoms linger.
But having diverticulitis itself doesn't mean you're automatically at higher risk for colon cancer.
No, the evidence doesn't support that link. They're separate issues, although sometimes distinguishing them initially can be tricky, which is another reason follow-up might be needed in specific situations. But routine screening, just because you had simple diverticulitis, isn't recommended.
Okay, so wrapping this all up, the big message seems to be a major shift towards less intervention for the common, uncomplicated cases.
Exactly. Trust the body's ability to heal. Focus on supportive care like paracetamol for pain. Monitor closely for red flags. But avoid the old defaults of bed rest, strict diets, and especially routine antibiotics. They just aren't backed by evidence for most people.
It really underscores how medicine evolves based on evidence.
It does. And it brings up an interesting point about diagnosis, actually. We talked about how hard it can be to tell right-sided diverticulitis from appendicitis.
Yeah, clinically identical sometimes.
Right. And even though we have amazing imaging now, like CT scans that are very accurate, the guidelines still emphasize the importance of the whole clinical picture for diagnosing acute abdominal pain, looking at multiple factors together.
So what's the final thought there, if the scans are so good?
Well, the provocative thought is this. Why, despite advanced technology, does making a reliable decision about acute abdominal pain still often depend on putting together several, sometimes non-specific pieces like no vomiting, very localized pain, specific blood marker levels, rather than just relying on one image or one test result? It highlights the complexity. It tells us that even with high-tech tools, careful clinical assessment, integrating all the clues, remains absolutely essential. Sometimes the experienced clinician's judgment, synthesizing everything, is still the most powerful diagnostic tool we have, especially when things aren't clear-cut.
A great reminder that medicine is still both an art and a science. Thanks for walking us through all that.
My pleasure.
And thank you for joining us for this deep dive. We'll see you next time.